is addressing an important issue, and that is what to do with ovaries after chemotherapy. And all kinds of things have been tried in the past to prevent the damage from chemotherapy to ovaries. Some things work a little better, others worse, and the most recent one is the idea of stem cell treatment of ovaries. And that's the subject of today. Pleasure having you. It's all yours.
Well, thank you very much. It's really a pleasure to be here. It's such a nice audience and intimate gathering. What was fun about, at least for me, about being asked to give this talk is, as I'm an oncologist, I'm not a fertility specialist, and so this meant I had to actually write a talk from scratch. I never give this talk. It's not one of my usual talks. But as was stated, I'm going to be talking about using adoptive cell therapies for treatment of chemotherapy-induced ovarian insufficiency. I do have some disclosures, although really none of these have anything to do with the topic. These are all related to my ovarian cancer work. And I do want to start off by really saying this isn't my talk I'm going to give. I'm giving a talk really for my colleague, my friend, my collaborator, Ray Anshin. Ray was an REI physician at the Brigham for about 20 years. He preceded me there by a few years. He was, I would say, a relatively new attending when I came to the Brigham as a resident. And we became friends through my training and as OBGYNs who were interested in science and research. And as I stayed on the faculty at Brigham Women's and opened up my own lab, Ray and I went from being friends and colleagues to scientific collaborators, and Ray became a wonderful mentor to me. So really the work I'm presenting today is really Ray's work. I'm going to talk about the genesis of his idea of using induced pluripotent stem cells for treating ovarian insufficiency, and then leading up to the work that he and I published together. This group is, I'm sure, well aware of this, but from an oncology perspective, it's interesting that women really bear the brunt of reproductive age cancers. And this is, we overall tend to think about cancer being more common in men than women, but that's actually not true if you look at reproductive age individuals. So about 1/10 of cancers in adults in their 20s to late 40s, or 1/10 of cancers occur in that age group, but twice as many cancers are diagnosed in women than men. It's only after 55 that you see the rate of cancer in men start to skyrocket past that of women. That's when we start to see colon cancers and lung cancers and prostate cancers. If you're talking about where the lost reproductive years are, it's almost exclusively women. And this is an increasing problem because cancer incidence in young adults is increasing more than any other age group. So in the last 20 years, we've seen this go up at more than 20%. This is data from the UK, but it's very similar in the United States. And sticking with the UK data, what you see is that when you're talking about very young women, so prepubescent women or adolescents, it's predominantly hematological malignancies, so the driving one, as well as things like brain tumors. But as you get into the core reproductive years, so 20s through 40s, breast cancer is certainly the most dominant disease. It's 43% of cancers in that age group. Now, risk factors for chemo-induced ovarian insufficiency, radiation is a big one. I'm not going to talk about radiation today because an irradiated ovary is a whole different problem. Hodgkin lymphoma, among the various malignancies, has the highest rate of ovarian insufficiency, and that has a lot to do with the chemo regimen that's used. The duration of therapy and dose certainly plays a risk, as well as the choice of agents. So particularly when we talk about alkylated chemotherapies, and I've highlighted cyclophosphamide because that's the backbone of chemotherapy for breast cancer. And so again, when we're talking about the reproductive age group, that's the one that's driving a lot of the ovarian insufficiency. Interestingly, diagnosis after puberty makes a big difference. So young girls who are treated with chemotherapy don't have nearly the degree of damage to the ovary as after the ovary has gone through menarche. And as I'll talk about, this is a problem that's compounded for women in their later reproductive years over 40. And we also know that women who have inherent germline DNA repair defects also have a bigger issue with ovarian insufficiency from chemo. So now the two are related. If someone's a BRCA1 carrier, she's more likely to be diagnosed with breast cancer in her 30s. And she's more likely to be diagnosed with the type of breast cancer that's going to require alkylating chemotherapy. However, because she has a DNA repair problem, the DNA damage that's induced by the chemotherapy increases the likelihood that she'll end up with ovarian insufficiency as well. So this is a compounded issue. And anecdotally, I'm sure many of you have seen that BRCA1 carriers in particular actually do tend to go into menopause earlier than when we don't have BRCA1 mutations. And there's debate about whether or not they respond more poorly to ovarian stimulation. I'd be curious to know what your collective experiences with that. But I will say anecdotally, I've certainly seen that, particularly for women who are closer to 40. BRCA1 carrier who's 40 going through an IVF cycle is much less likely to have a successful outcome. The regimen does matter, as well as age. So these are some of the more common breast cancer regimens that we tend to use. So AC is adriamycin and cyclophosphamide, and then CMF is one of the other more common regimens, which is cyclophosphamide, methotrexate, and 5-FU. But you can see what a difference age makes here, because if you have a woman who is 40 and receives a standard regimen of CMF, her risk of becoming amenorrheic is 80 to 90%. It's extremely, extremely high. Whereas if that same woman is, say, in her 30s, there's about a 1 in 3% chance that she develops amenorrhea. So it's not just the regimen, but also where a woman is in her reproductive lifespan. It makes a big difference as well. Now, this might seem obvious, but we don't entirely agree why chemotherapy is bad for ovaries. So there's two dominant theories for why chemo is gonatotoxic. And I'll get to the idea that there might be a third mechanism as well. So the first is the idea that chemotherapy is directly toxic to primordial follicles. So certainly if you take a mouse and you administer alkylating chemotherapy agents, you'll see double-stranded DNA breaks in the oocytes themselves. This activates DNA repair pathways, ideally, but more commonly, the degree of DNA damage is going to lead to activation of ATM and apoptotic pathways like VAX and BAC, and those go down through the cytochrome C released from mitochondria, and you get apoptosis and follicular atresia. That's what generally happens. And as you can imagine, if you are someone who has an inherent DNA repair problem, like a BRCA1 mutation, it's even more likely that you're going to have apoptosis as the outcome. Now, the other hypothesis is what's known as accelerated activation, the burnout hypothesis. So this idea is that actually chemotherapy doesn't damage primordial follicles. The thought is that what happens is it depletes the secondary follicles, but the loss of the secondary follicles leads to more activation of more primary follicles, and so you start speeding up the process of follicular development. And so the idea here is that as you deplete the resting pool, you eventually end up with a loss of primordial follicles. And so the thought there is that it's this apoptosis of the growing follicles leads to a loss of the inhibitory signals, which would recruit other follicles from developing. So you get more primordial follicle activation and this sort of burnout phenomenon. And so if you think about how GnRH agonists might theoretically work to prevent ovarian failure, this is really what you're trying to prevent. There's nothing about GnRH agonists which should prevent direct DNA damage. The only thing it can really do is prevent new follicles from being recruited and presumably becoming damaged. Now, the other thought about this hypothesis is is that with repetitive dosing, this is going to become a greater problem, right? Because you can imagine that every cycle of chemotherapy that someone goes through, you deplete another round of follicles. Now you start to have more primordial follicles being activated. You hit them with another cycle of chemotherapy, and the cycle repeats itself. Okay, so this is just want to go over some experimental evidence. This is work from Amy Winship. Relatively simple set of experiments. They delivered dacarbazine, which is one of the drugs which is used in some hematologic malignancies and brain tumors. And they looked at ovaries from mice 2 weeks after administration. And just looking at the follicles very clearly, it's the primordial follicles that are dying off. You don't see changes in the levels of later follicle development. And this is quite similar to what you see in humans as well. So there's this very interesting paper where they took ovaries from age-matched women, very young women. So this is ovaries from two 22-year-old women. The arrows are pointing to various primordial follicles. This is a control woman's ovary, and this is a woman who's had CHOP chemotherapy. And you can see that there's primordial follicles go away. And if you look at different regimens, alkylating regimens, you'll see loss of primordial follicles. If you look at non-alkylating chemotherapies, you don't see that same phenomenon. Now, again, this is a process that's exacerbated by age. So in the same work by Amy Winship, she said, well, what happens if I take mice and I do aged mice instead of young mice? So mice also have age-related follicular atresia. So you can see that there are fewer follicles in the 6-month-old mice. But when you give alkylating chemotherapy to aged mice, you have even more rapid loss of primordial follicles. And again, looking at human data, if you look at sort of natural age-related follicular atresia, chemotherapy essentially accelerates this process. So if you look at that line, it just shifts downward after chemotherapy. Now, the reason I bring that up is that it's not a short-term problem. So this is data looking at childhood cancer survivors who received alkylating chemotherapy and what happens to them over the rest of their reproductive life. And so what you can see is that, yes, initially as they go through adolescence, their ovarian function appears to be normal, but they have this steep drop later on as they get into their 30s, well beyond what you would see in siblings not given chemotherapy. And so short-term studies, because many of the clinical studies are looking at 6-month outcomes, 1-year outcomes of amenorrhea. If you look at long-term outcomes, you get a much clearer picture about what the actual risk of ovarian insufficiency is. So this is looking at a group of adult cancer survivors in Ontario. This is about 20,000 women in this particular study. And what you can see is that it's not really a 1-year problem. It's a 1 to 3 to 5 year problem as far as when women actually get diagnosed with ovarian insufficiency. And so, for instance, the ovarian insufficiency rate among women with leukemia, so the average age of diagnosis for cancer in the study was 29, the POI rate was 21%, but usually it was happening about 2.5 years later. And even some cancers that we don't necessarily think of as having maybe a particularly high POI rate, we do see that there's at least some increased relative risk. Think about things like thyroid cancer, for instance. Now, this is a problem which gets magnified because there's two other phenomena to think about. The first is that just societally, maternal age at first birth is increasing. This is true actually across demographics in the United States. So whether you're talking about urban areas, small cities, or rural areas, age of first maternal birth is increasing. I couldn't find CDC data that was more updated than 2017, but I know it's across 28, at least in large metro areas, and at least 31 in many large metro cities. And of course, your pregnancy rate per IVF cycle declines with age as well. So these are two trends which are working against the fact that now you're dealing with a shorter window. So if we're thinking that the average age of ovarian insufficiency for, say, a woman who's diagnosed with breast cancer in her early 30s, if she's going to develop POI, it's going to happen in her let's say 35, 36, she's already moving now to a point of falling off the curve as far as her likelihood of IVF success. And that's really the nidus for this, is that when we talk about options for fertility preservation, generally in the conversations that I have with cancer patients, it's embryo cryopreservation, oocyte cryopreservation, ovarian tissue cryopreservation. All three of those things require the ovary to be working at the time that the patient is presented for her consults. If the ovary is already has ovarian factor deficits, none of those three things are going to be helpful. Plus, obviously, any of these techniques requires time. So, from an oncologic point of view, can the treatment be delayed? Requires funding and access. And there's no rescue option for an ovary which already has a defect. And importantly, none of this deals with the endocrine effects of ovarian insufficiency. So this is only talking about the fertility aspect of it. And one of the things that when Ray and I started doing this work together that Ray was very interested in was thinking about the other consequences of ovarian insufficiency. So accelerated aging and osteoporosis, premature cardiovascular disease, sexual dysfunction, all the effects of estrogen loss. Even for women that might not be interested in fertility per se, the consequences of the endocrine consequences of, for many of these women, 20, 30 years of hormone replacement therapy is also something important to think. So the crux of this work then is how can we restore ovarian function? And when Ray initially launched these experiments in the sort of early to mid 2000s, there were three design requirements at that time, because this was just after a lot of the work in embryonic stem cells had come out. And there was certainly a governmental push to avoid embryonic stem cells. You also were looking for a therapy that was patient-specific, so ideally some sort of autologous therapy, as well as a lot of concerns about using xenografts. So the idea that if you were culturing cells using mouse cells or some other species as feeder cells, or using some sort of adoptive therapy of animal cells into humans, could you be at risk for zoonotic infections and issues like that? So as Ray was thinking about these sorts of problems, there was an explosion of papers which came out. So this is all these papers came out in 2008, 2009, really, in Science and Cell, looking at induced pluripotent stem cells. And so these are the Yamanaka factors, the idea that taking a somatic cell, and most of this original work was with fibroblasts, and then overexpressing these 4 transcription factors could reprogram a cell in such a way that it allowed development of all tissue types. So very exciting work, but these early efforts in induced pluripotent stem cells had some problems. The first was that if you look at these original papers, it's an extremely inefficient process. Some of these initial ones, the efficiency of actually reprogramming a cell was 1/1000th of a percent. It also had very long derivation times. It took months and months to generate these cells in the lab. And it was very difficult to generate biocompatible feeder cells that allow you to sustain these cells in culture. So there was a lot of interest and enthusiasm about the idea, but it was very unclear how you could direct the differentiation of the cells, how you could make it an efficient process, and how you could make it theoretically safe. So at that time, another lab at Harvard came out with this paper, which caught Ray's eye, which was they were looking at using induced pluripotent stem cells for hematopoietic cells. And the key observation here was that if you took a cell which was earlier in differentiation, it was easier to reprogram than a cell which was terminally differentiated. And that might seem obvious, but it wasn't at the time. Here, what they were looking at, if you just compare these two dishes, looking at pro B cells versus mature B cells. So as far as how many stem cell colonies you get, depending on what you started with. So they were able to increase the efficiency of generation by 300-fold. So now instead of getting 0.1% of cells being induced, they were now getting a third of cells. So it was a dramatic improvement. So this was the key insight for Ray in the way he wanted to take the work, because Ray's thought was, well, if it's earlier to reprogram cells, the earlier a cell is in differentiation, it's earlier to reprogram, why not use amniocytes? So why amniocytes? Well, they're readily accessible being amniocentesis. They're very primitive cells. They're essentially exfoliated embryonic cells. Right? They're very easy to grow, and they proliferate very quickly. And Ray had a hypothesis that it would be easier to reprogram them because they're epigenetically more similar to an embryonic stem cell. So if you think about it, a cell is being exfoliated from an embryo, it's probably closer to embryonic stem cell than a adult somatic terminated cell. And so this was the first paper that Ray really wrote on this topic, was the ability to use amniocytes as iPS cells as well as the feeder cells. So this is from that work. What Ray showed was that if you took either mouse or human amniocytes, and you infected them with the Yamanaka factors, or in mice, you actually only need 2 of the factors in order to reprogram them. You could get colonies of cells that could differentiate into all 3 layers, and then the way that you test that in vivo is you inject them into a mouse, into the thigh of the mouse, it forms a teratoma, it forms a dermoid. You can see that you've got all 3 layers. And you don't see that if you look at the original amniocytes, or if you look at just fibroblasts from the mouse. So this was the initial observation. Now, in that same work, Ray also looked at gene expression, comparing human embryonic stem cells with these what he called human amniocyte-derived induced pluripotent stem cells, so these HEDFs. So looking just across the transcriptome, the correlation of these induced cells was very, very, very similar to embryonic stem cells in a way that you don't see between naturally occurring human amniocytes and human embryonic stem cells. And so it seemed like that there was, that reprogramming was almost complete. So we'll talk about almost complete, not quite. And so there was this idea that maybe what you could do is you could take amniocytes from an amniocentesis, you could collect these, you could culture them, you could use the amniocytes themselves as the feeder layer, or just grow them in a pool, differentiate them, and then you have a patient-specific therapy. You can imagine using amniocytes to repopulate tissues from basically a woman could serve as her own donor for stem cell-based therapies later on. But then that led to the question of, well, could iPSCs yield steroidogenic cells? So Shane, who was an REI fellow with Ray and me at the Brigham, looked into this during his fellowship. And the reason why Ray decided to focus specifically on steroidogenic cells is that when you grow induced pluripotent stem cells in culture, or just naturally embryonic stem cells, they form these aggregates called embryoid bodies. They spontaneously will do this in culture. And a certain fraction of these will make sex hormones. They'll make estradiol and progesterone. And what essentially happens is they recapitulate ovarian development. So if you look at these embryoid bodies, they look like natal ovaries, very, very early prepubertal ovaries. And over time, as you culture them in the dish, they sort of spontaneously will go through a maturation process, which looks like ovarian development. And so these embryo bodies that attach to the culture dish, they express ovarian markers like AMH receptor, FSH receptor, FOXL2, but then they also secrete high levels of estradiol. So Ray had observed that some of these embryo bodies stick to the dish and some of them float. The ones that float don't make estradiol. The ones that stick make estradiol. So for these as attached or suspended embryo bodies. But the problem was identifying which were the right embryo bodies that you wanted to culture, because it's a small percentage of the ones that are spontaneously undergoing this ovarian differentiation. So to look at that question, what we did was isolated neural granulosa cells from adult ovaries, and then from mice, and then compared these to postnatal day 2 ovaries, so very immature ovaries, and then looked at the gene expression between the adult neural granulosa cells, the postnatal day 2 ovaries, and then these embryo bodies. So essentially looking for a set of shared genes between the attached embryo bodies. So what were these ones that were making hormones and had ovarian factors that we wanted, and that were seen in these sort of very early ovaries, but not seen in adult granulosa cells. So essentially looking for a marker that you could use to select the embryo bodies that are going to be most suitable for making a steroidogenic induced pluripotent stem cell. And it turns out that it's AMHR2. That's what you're looking for. So what we found is that there's a very small percentage of cells that express AMHR2. If you sort those cells out by FACS, they're the ones that express high levels of epicytic receptor, FOXL2, and they make higher levels of estradiol. And in the same paper, it was shown you could do this with human cells as well. And not only did they make high levels of estradiol and express ovarian markers, but you could culture them for weeks in culture. Weeks and weeks and weeks and weeks, months in culture.
Do you need to provide exogenous androgen for them to make estrogen?
That's a good question. Yes, eventually. They need substrate, but you keep synthesizing it, yes. Yeah.
I assume you saw induction of aromatase.
Yes. So I didn't show the figure here, but in the same paper, they add aromatase inhibitors and show that hormone production goes away. They add testosterone, hormone production goes up. So they did test the synthetic aspect, yes. Right. But you would have to continue a source in the culture.
This is interesting because this receptor for the ovaries is most frequent in adrenal glands.
Yeah.
And the adrenal glands have a common predecessor with ovaries. So I didn't know that. That's very interesting.
Now, Ray, question, again, this is a spontaneous process, right? So the question is, if it's a spontaneous process, why is it happening? And Ray thought, well, if there's an epigenetic memory, that's important. So maybe what you want to do is make your induced pluripotent stem cells from a tissue that's most similar to what you're ultimately trying to reprogram it into. So the thought was, if what you want to make at the end of the day is an induced pluripotent stem cell, and you want to induce that stem cell to become ovarian cortex, take a cell from the ovarian cortex, reprogram that into a stem cell, and then differentiate it. So turn that into your cell line, and then have a population. And so, and you probably know Zev, he's here in New York now, right? Zev and Ray did this work together, looking at could you repeat this process, but instead of using amniocytes, use granulosa cells. And of course, amniocentesis is not done as frequently anymore as it once was, but IVF is still done quite a lot. And every time you do an IVF cycle, you get a huge amount of follicular fluid, and it's full of granulosa cells, right? So they had the idea, well, could you use the granulosa cells that were discarded from an IVF cycle? And the short answer is yes. So these are what we refer to as GRIPs, or granulosa cell-derived induced pluripotent stem cells. And so both in mice and in humans, they express, again, all of these Yamanaka factors once they're transfected, they differentiate in vitro and in vivo into serotomas. But what was different about granulosa cell-derived induced pluripotent stem cells from the amniocyte ones is that these preferentially make estradiol. They don't make progesterone. There's not very much of it. And if you took them, again, they would go through this sort of suspended embryonic body and then attached embryonic body. They will make preferential estradiol. They seem to retain some sort of epigenetic memory that makes them want to make estrogen producing estradiol. So you've got a cell type which is doing two things simultaneously. It is still making estradiol, like a granulosa cell you expect to, but it also now is